Ok, volvemos a estar en directo. Ya estamos todos listos otra vez. Y bien, ahora para mí es un gran placer. Presento otra vez, es que todo el rato estoy diciendo lo mismo, lo sé, ¿eh? Presento a un amigo, es que todos son amigos míos. De verdad es que toda esta gente son mis compañeros de trabajo, ¿no? Entonces, Nondas es, yo creo que uno de los técnicos más famosos que hay en el mundo hoy en día. Es adorado en todos los países. ¿Por qué? Es adorado porque es una persona súper cercana y súper generosa. Cuando tú vas a un curso de Nondas, te das cuenta que es el profesor más trabajador que yo he visto nunca. O sea, no hay ningún trabajador que esté más implicado con sus alumnos que este hombre. Entonces, para mí, este es un gran placer presentarlo. Nondas, are you here?
Hello, how are you?
Hello, my friend.
Hola, August. First of all,
Además, Nondas, hay que felicitarlo mucho porque acaba de ser papá, ¿eh?
Sí. Sí, muchas gracias. Sí, es increíble. Thank you very much for this invitation.
Nondas, was a
Thank you
pleasure.
very much. Thank you for your nice words. It's a big honor for me, these words from you. I hope all the people around the world enjoy this activity that you made real. Thank you very much for this, all of us. It was really nice. Idea. And I hope all the people around the world to be healthy and finish very quickly all this adventure. Yes, I wish the best. So.
Thank you, Nondas. Come in.
Can we start?
Absolutely, you can start. Everybody is waiting you.
Okay. Okay, so. It's okay. It's working?
It's working. Perfect. Absolutely working.
Okay. So, hello, dear friends. The presentation is about a digital approach for a lithium disilicate case with a unique way. Normally, when we do pressable or pressable with CAD/CAM milling, there is a lot of human work. I love human work. I'm a not so digital person, very traditional and manual person. But of course, we need to combine digital and human this time. So the case has to do with this person. The name is Panos. He's an ophthalmologist doctor, 53 years old. There is a lot of worn dentition, about 7 millimeter reduced vertical dimension of occlusal. There is a lot of bone defect on 21 due to the occlusal trauma. There is occlusal disorder, anterior guidance loss, and extensive cervical erosion. Additionally, this patient, it was really funny. So we had the opportunity to get some nice, funny photos for this presentation. So we had to think about to do it like traditional, analog, I like analog, or to make it more digital. My opinion is always we need to combine. We need to combine the technology because we need the technology in order to work with modern materials, new techniques, more aesthetic techniques, and also to combine the human skills, the talent of the technicians in order to get the better results. So there is in the market now a system that we can work with pressable ceramics with a digital workflow. Let me explain. This is the previous situation of the patient, the portraits. So as we can see, there is a lot of erosions and really we cannot see any mandibular teeth. A lot of vertical dimension of occlusal loss, and we can see the lips, how the lips in the right photo, how the lips, it's getting down here. Okay, so we have aesthetic problems, a lot of erosions, there is no cusps, there's a flat occlusal areas, and the smile, portrait, we cannot see any lower teeth, nothing. And of course, there is a different position of the lower jaw. It's more front because of the interruption of vertical dimension of occlusal. And this made a lot of fractures, chippings in the enamel of the 6 anterior teeth, the facial surfaces of decompressed forces. As we can see here, the vertical dimension with calm muscle tone, and then with occlusal. I'm going back, I'm going forward. I'm going back and forward. There is a big difference. And also the intermaxillary space between centric relation and vertical dimension in rest position, it was huge, about 10 millimeters. So we had to restore all this distance. It was a big volume and a big space. Intraoral photos, close up, a lot of erosions, missing parts of enamel, facial parts of enamel, posterior, anterior, really disaster. No occlusal and cusps, nothing, everything was flat surface, lateral views. And there was another problem. On tooth 21, 9 for USA, it was compromised with moderate to poor prognosis, but after the occlusal equilibration and the surgical periodontal therapy with bone graft, the mobility was less. We can see here, the problem it was that the patient, we wanted to extract and put an implant, but the patient didn't want to do that. It was afraid. He said, no, let it like this, and when I miss the tooth, I will put an implant, but not now, or a bridge. He was afraid, he didn't want to extract the tooth and put an implant. More close-up photos, we can see the problem with the 21 central occlusal views, a lot of enamel. So we had to think what kind of restoration we need to do. Crowns, partial veneers. Of course, we needed something that if it was partial and minimal advancing, so something that we will get a good cementation. So we just focus mostly for glass ceramics. So it was not a lot of damage in the lingual and palatal surfaces. So we decided to make like 3 to 4 partial tabletops for the posteriors and veneers for the anterior teeth. Occlusal view for the lower anteriors and the posteriors. A lot of composites, fractures, erosions. So we decided not to touch the lingual surface, but to work to the occlusal, mesial, and distal and facial surface that it was the most of erosions. Maxillary, the same, was not so big erosions in the palatal surface. So we decided to keep them. And also the patient didn't want to grind a lot his teeth. He was afraid. Okay, what we did, first of all, we get the first scanning, intraoral scan, in order to do what? To make provisionals with nothing of preparations. There is no any preparation, nothing. The teeth as it is, with the erosions. The idea it was with these provisionals to verify the final vertical dimension of occlusal, to verify aesthetic and phonetic for the patient. As you can see, there is no any preparations. Mandibular scanning. And then we get occlusal records. We had prepared incisal guidance in order to verify how much we will increase the occlusal, the VDO. So we put it in the mouth, we put it on the anterior teeth, and we scan upper and lower, the upper and lower teeth. Then we proceed to make the first diagnostic models with printing without any preparation. And then we proceed to make provisionals. This is the acrylic provisionals. It was milling PMMA provisionals without any grinding of the natural teeth. Just we get over of this like a cells. And we didn't care about to be like supra or subgingival or whatever. The only thing it was to verify the VDO, phonetic, aesthetic, color, and position of the teeth. So we get some photos, some informations of these PMMA provisionals. And the comments of the patient, it was like, I like them. I like to be a little bit more round, not so square. So we tried, and I disagree about this because I told him that it's not possible before to have like a lot of fractures, a lot of aggressive details, and then to pass in a very smooth, round result. You will change your appearance, your aesthetic completely, and it will be very visible for your friends and relatives, whatever. So finally, he agreed, and just he wanted to make a little bit more bright colors, to change the color and make it a little bit more bright. Then, after 1 month, we proceed to the final scanning with preparations. We prepare the teeth, occlusal, facial surfaces, and veneers for the 6 anteriors. The high definition scanning. So we finish the scan, occlusal, record. We get the STL files. And then we have the first images of the STL files, upper and lower, lateral views, palatal, lingual views. You can see the preparations, and occlusal views. As you can see, we decide to make, the clinician decide to make peripheral chamfer of the posterior teeth in order to get better cementation, a bigger surface of enamel for better cementation. And then in the lab, we proceed the lab work. First of all, margins, to verify the margins. For the lithium disilicate crowns. And then to verify the margins in order to make the alveolar model. We do both of work at the same time. So we proceed for the alveolar model. Insertion paths of the dies, alveolar dies. And relation upper and lower with a new vertical dimension of occlusal, and then we make some space for some difficult undercut areas, occlusal as well. Areas that it will be make difficult to put the crowns in the final position. And then we proceed to make the full contour setup according the provisionals and according the altercast that we have. We work with opposite, we check with the antagonistic teeth with the altercast. So we have all the time info about the Spee and Wilson curves. Then we proceed to remove of the facial surface the amount of material in order to apply ceramic aesthetic material. So it will not be completely monolithic. It will be only palatal, occlusal monolithic, and facial layering, veneering. Then we adapt on the model. And the crowns, the crowns of the library adapted in the margins. And it's ready. Then we get STL files about the alveolar models, alveolar dies, and STL files about the final restorations. Then we proceed to work with this system. Printing from a company Dechema and furnace for press and the software that will permit us to design, first of all, the models. In 50 microns accuracy, and then to design and to put on the table of the ring, of the pressable rings, direct the crowns, the digital crowns, without any wax, without any screws, nothing. So we get the digital STL files of the crowns, and the software put them direct on a simulated table like the ring that we use for pressable, for pressing. Even the plank areas are printed. We have simulation with the walls of the ring. So direct in the software, we put the crowns on the ring, and then we get also the alveolar printed models and printing dies. Ready? And after printing, we have the base of the rings that we will use them for pressable technique, direct, printed the crowns and the space for the plank in this base. So there is no any human hand that puts screws or something. It's getting automatically from of the program in this position. Occlusal, another view. The details are really, really good, very fine, high definition printing. And we use this material, the nano-lithium disilicate for pressing. We combine between low translucent ingots and between A2 and A1. So we have the ring, we have the cases, we put the plastic ring together. And then we fill the ring with investment material for pressables. We remove, and it's ready after about 30 minutes to put it in the burnout furnace. At least after 1 hour, we get it out, and then we put the ingots. We can combine between 1, 2, or 3 different ingots at the same time, at the same pressing. And the press is simultaneously for all of them. We take them out, has to cool in the room temperature, and then with glass plastic sand, we remove the investment material, and the restorations are ready. Then we fit the cases, the models. We do the first foundation, wash bake. And then it's time for the factor. We apply ceramic, we do the veneering, layering in order to get the aesthetic, translucent, color, effects. And this is the final restoration after cementation. The final portrait.
Hi guys, a warm smile from Greece, and don't forget, apart from basketball, we know how to make teeth. Yes. Enjoy.
This is the final portrait of the patient, and we finished. Thank you very much. Muchas gracias.
Nondas, thank you so much. De nada. ¿Qué entiendes bien español? Estamos perfecto. Vamos, es increíble como todos estáis cuadrando los tiempos. Vamos adelantados al tiempo. Es increíble. Nondas, I have different questions. I know that you understand very well Spanish. Which intraoral scan do you prefer?
Intraoral scan. I told you that I'm not so digital person. So, and also I don't want to make any advertisement. I don't have a lot of really knowledge about intraoral scanners. I think it's more work of the clinicians. So, and really I don't have a lot of experience. I work some, like many technicians, a little bit more traditional, but as I told you, now we need to combine. We need to combine technology, modern materials with skills. So I get some digital files, but really not so much. But it's getting more day by day.
That is true.
Really, I don't have any really one specific preference like this scanner or this scanner. Okay.
Yeah, this is true. Huh? And if you print, do you have the same quality as milling?
As milling? Do you mean for model?
If you print the veneers, you have the same quality if you milling the veneers.
It was really good, and it was the first case. Now I have here the whole system, and I make some tests. But the first impression, it was really impressive, and it was in 50 microns. The printing 50 microns, it was really good, and result really good. I want to try a little bit more accuracy also. We'll see. It's it was the first case that I did like this. Really, we didn't have some problems. It was the most important that it was 24 crowns. It was all the same. We didn't have the problem of the human mistake. Like one of them, it was like not so good margin fit. Because why? Because I was tired and I made a mistake. You understand? All of them, it was exactly the same tolerance about fitting.
Okay. And the last question: what brand of Disilicate, lithium disilicate do you use?
This one, it was the Amber of Haas. Lately, I use this.
Okay.
This company.
Okay, Nondas. Thank you very much.
You're welcome. Thank you very much for this opportunity, and stay healthy. And I hope the best for Spain.
Thank you so much. Stay at home, please, and take care. Huh?
Thank you, my
Big
friend.
kiss for all the Greece dental technicians and dentists. Big
you
kiss.
too. Don't go out with your bicycle. Stay home.
Okay. Yes. Kiss. Bye. Bye. See you.
Bye.
Vamos a continuar. Ahora tenemos a un full digital. Es curioso porque venimos de Nondas, que es un full analógico, ¿no? Es un prehistórico como yo, Nondas. Y ahora vamos a un digital. Oye, queremos agradecer todos los comentarios que estáis haciendo en redes, súper bonitos. Muchísimas gracias. Oigan, bueno, tenemos aquí a Florin Cofar. Yo creo que todo el mundo conoce a Florin. Florin es un rumano que de veras es un crack en todo que es digital. Para mí él y Loran son lo máximo que hay. Yo quiero un poco de vino tinto contigo, amigo.
Yes.
Okay, yo creo que todo el mundo conoce a Florin. No le vamos a robar más tiempo. Ya digo, digitalmente es de lo mejor. Thank you to accept our invitation. It's a big pleasure to be here with you.
It's my pleasure, and lecturing has never been more comfortable than it is now. We have to see also the good sides. No, we are at home, very comfortable, very nice. So thank you for inviting me. Should I start?
Absolutely, you can start.
Okay.
Ready.
Let me share my screen. Okay. Good. So I want to talk to you a little bit today about some problems in digital dentistry, which exist in any workflow, and I will pick a specific one. Obviously, there's more, but I want to talk about the dark substrates, managing the dark substrates. Now, before I go into that, I really want to put a little bit of context, just to show you in a few lines how we work, what is our workflow, because as you well know, there's 55,000 ways to work. So just to put things into context, I will make a small comparison to understand our way of thinking with architecture, which has always been a huge inspiration for me in terms of thinking, planning, treatment planning, etc. You know, the whole thing with thinking with the end in mind, I think nobody does it better than architects. And I think there's a lot to learn. And if we are to talk about the process of how an architect does it, if you have like a simple project, and here I just made a parallel between a project of my 2 boys' room. My wife's an architect, by the way, so she made the small project I'm gonna make a parallel with, and what we do as dentists. So what they normally do in architecture, first they start with data, okay? So, which means pictures, measurements, you know, the basic things. And for us, the same thing happens in a consultation, where we see the patient and we get a number of files and file formats that will give us the information required for planning. For example, on portraits, we have the relationship with the face. On CBCT, we see the bone availability. On scans is the canvas on which we plan. On videos, we see the lip position and all of these things. So the second you have the data, in architecture, you always start with a 2D plan. Now, why is that? Because these people are the best in 3D. However, they always start in 2D. And they have all the softwares. I mean, everything we have as advanced software in dentistry is somehow imported and inspired by either architecture or engineering. But the process doesn't matter if it's on a software or on a piece of paper, always starts 2D. Because to put it simple, it's systematic thinking. And if you want to think about it, every 3D file we see in dental, we see it on a computer screen, which is also 2D. So it's a bit different what we do, because we interpret 3D information in 2D images. So after you have the 2D plan in architecture, then you have to scale it to 3D. So you first fix 2 axes out of 3, then you scale it up. And a huge part of, for example, interior design, which is the example I'm giving, is the use of libraries. Library means there's an object that exists as a file and also in reality, so you can buy it. And the one from the library, use it to make the project. And once the client accepts, you can go to the store and buy the actual object. So it makes things very predictable. Now, once you finish all of this, you render this. So you make like computer generated imagery, like the one you see here, of how the project will look at the end. I need to see this image instead of this image, for example, to understand what's it gonna look like. Now, in terms of dental, if you think about it, libraries for me are at the center, at the core of digital dentistry, because if you think about pros, we use libraries of teeth, which is like predefined chunks of information that speed up the process. If you think about guided surgery, you need libraries of components, otherwise it would not be possible. Libraries of brackets for ortho, etc. So libraries are at the core of it. Now, in prosthetics, design is these 2 things. You need to select the library and you need to position the library. Now, the selection is generally done in 2D and the positioning is done in 3D in a CAD software. This is how we do it today. So in 2D, we use SmileCloud, the technology which we were involved in developing it, where this works as a library search engine where you can search in real time for certain parameters specific to the case of a library you're going to use. You can also render it in real time. And then once you select something and what the patient
Florin,
also can see and choose. Yes?
Florin, sorry. You can
Yes.
get closer to the microphone, please.
Yeah, this
A
is the
little bit
microphone.
more? Oh, okay.
Yeah, like this.
It's closer?
It's okay.
Okay. I think yes. Thank you so much.
Mm-hmm. So once we select the library, then the positioning of the library will finalize the design, and you position it according to what? To biology, to functional envelope, to phase, all of the principles that we know. You functionalize the library by positioning it, basically. Now, of course, you can functionalize the library by changing the library, but that is not really predictable, and we try to avoid that by, altering it. So in terms of the 2D, here's how it works. This is an example like from the technology we use, from SmileCloud, where you can just input the parameters what you want in terms of design. You can change the lines, the smile curve, the zenith curve, the proportions, papilla points, all these things. And you search in real time for libraries from a huge database that fit in your search criteria. And you can see them in real time. Now, this is hugely beneficial because you can do this in real time with the patient. And all of the options are viable options in terms of the final ceramics. And also you can just do like a quick preview for the patient to understand. So you're somehow reversing the process. Normally you have like an entire process to get here, because you need to print, you need to do the whole design, print a model, etc. And it's a liability. You can waste time, resources, everything. The way we do it is we select the library, agree on the patient, and then we start the process. So we don't waste resources and time. Now, this library at this moment, they are very, very cheap. And in, I think, 1 or 2 weeks from now, they will be completely free. So it's really nice because you can just choose one, download it, and then you go to 3D and you're positioning again with according to the principles you decided. Okay, you end up with a 3D model that you can print and you can transfer to the physical reality. So the patient can see, like the traditional mock-up. Now, if the case is additive, it's worth to do this. If the case is reductive, you don't even need to go through this step. Then, clinically, you need to do everything according to what you plan. So you need to recontour the tissue, prep the teeth according to these things, and then you can be very predictable in milling monolithic restorations that you can copy the shape, exactly what you chose, staining it a little bit, and we know already that this can be very predictable. You can see the design in PM in bisacryl on one side and on ceramics on the other. And this works very well in ideal scenario. Now, what you saw is the happy path. Happy path means what happens when everything goes perfect, okay? And this is, a very small part of the reality, because in reality we have multiple problems that we have to deal with, and I will just pick one for today. And this is when we have like dark teeth, for example, because when we have beautiful substrate, monolithic works very nice. We know this very well. It's not difficult to achieve nice results. However, whenever you have dark teeth or dark roots, there is a problem, because when you work in monolithic, you don't have the optical tool set from layering. So you will be much more vulnerable to this problem than in analog. And there are 3 ways you can overcome this problem. So again, remember that one way can, again, depend on the technician, and this is by staining the ceramics. So let's say we have a case like this, and here you can see we have a lateral that is dark when we will remove this composite. First, like in every single case, we do design, we print it, we try it in. Then we crown lengthen according to it, we prep according to it. And you see we have a dark lateral. Now, if we just do the normal stuff, obviously this lateral will have a different color than the rest. Now it's very important to understand how color is what is gonna result from. So let's say we take a shade of a monolithic block, doesn't matter multi-layer or not, and we are gonna mill that lateral. The final color will be a couple of things. Will be the shade you choose, factored by the thickness. So for example, if you take like a B1 block and it's 0.5, it's gonna be B1. If you take a B1 block and it's 1 millimeter, it's gonna look like a BL. So thickness is very important. Second, it's factored by how dark the substrate is. That also impacts the color. Is factored minorly by the cement you use, which you don't really want to mess with around too much because it's not predictable. Is factored by the stain, by what you paint on the surface of the ceramics, and at the end also with the dark inside of the mouth. So all of these things come with the color at the end. So one way to do it when the color is not so severe, when you have like a mild discoloration, like in this case, is generally speaking, you prep slightly more. You don't have to prep a lot more. And here, what you can do is you can stain inside or outside of the restoration. And here's an example. You can see that the veneers have different thicknesses, so they are stained differently. Now, the best guy in the world to describe this and to teach this is for sure Paolo Cano, who has its technique of multiple layers and multiple stains. But just to put it simple, in this type of case, you can stain outside of the restoration. And in this case, because the restoration is more thick, you need to add chroma to it, because otherwise it's going to be more white than the other teeth. And also to block the dark coming from the substrate, you stain it inside to block the color. When you stain inside, the stains are metal oxides. So technically speaking, you will lose adhesion. However, if you glaze on top of that, you regain adhesion, which means when you design this type of restoration and you know you're going to stain inside, you should increase the cement gap, not the margin gap, but the cement gap of the restoration. Otherwise, you'll have trouble adapting them. So in this case, we stain, and also you can see here, the critical area in this type of cases is at the margin level. The margin here, you want to place it subgingivally, and then also think about augmenting the tissue a little bit. Otherwise, you're always going to have like a gray halo. So we bond the stain restoration, we augment with a soft tissue graft, and then this is the result at the end, and this is in polarized light. Now this works fine, however, it's technician dependent. So if you depend on like analog technician to layer in a nice way, it's just the same, but more difficult because staining has less of a tools than a guy that does layering has. So you don't really get away from the requirement of the technician being highly artistically skilled. Now, another option here is coping. This is easier for the dentist because the dentist just has to prep more. So here we have two laterals, and in these two laterals, we're going to prep more, and we're going to make, like, we're going to mill a crown and coping. And you can see how it looks. The coping, you can make it Emax, you can make it zirconia. And they're going to be bonded together in the lab, okay? And then you receive one crown that will block. Now, the advantages of this technique is you can, technically speaking, block any color. So it doesn't matter if the tooth is black, for example, like in this case. It's easy for the dentist, just needs to prep more. What are the disadvantages? It's expensive. Technically speaking, the technician has to make 2 restorations. It's time consuming because many times you cannot make them both in one CAD design. If the space is thin, you need to make the coping first and then the technician makes like manually a thin chamfer there and rescans. I'm talking about if you want to get very good precision. Another disadvantage is you have 2 interfaces of cement. So it's also technically sensitive. But again, it is an option. So in this type of case where you have dark teeth, you have, for example, here zirconia. Actually, I don't remember in this case if it's zirconia or Remax, but either way, it's stained to get more chroma because otherwise you will have a problem blocking the white. Then you have the ceramic crown on top, and then you can block it very nicely. Now, the last part I want to tell you, a very nice technique, is one that we're also going to publish next year in QDT 2021. And this is something we have been doing lately. And since we do this, we rarely do the other 2. I mean, the staining you still have to do in many situations, but the coping I kind of like discarded, let's say, to this one. Here's an example again where we have dark teeth and dark roots. And like in every case, you do a design first. And to show the patient the modifications of the design, you put the mock-up on top, and then you're going to paint with the black marker the areas that you're going to reduce. And then I take like a pink composite, and I also mask the areas of the gingiva, because otherwise when you do the mock-up, it's going to be an ugly high contrast area with the bisacryl, and it doesn't look nice. And not only that, but that's exactly what we plan to do. So the pink that I put here will be substituted by soft tissue augmentation in those areas. So here again, once the patient accepts, we can go and cut the area that we painted with black, and then we crown lengthen according to the tissue. And then we restore the biologic width. We use a flapless technique here with an ultrasonic tip. Again, credits to Maestro Paolo Cano for this technique. It's amazing, simple, and very efficient wherever there's thin bone. And in our part of the world, most patients do not have a lot of buccal bone. We check that everything's okay. I always want to check with a silicone key according to the final design that I have, the length that I planned for and all this. And then I remove the old restorations, and this is what we have under. So this is quite challenging because you need to block both the substrate and the roots. So what I did here is I prepped actually here I prep like a double chamfer. So one chamfer where I want the restoration to start, and a second chamfer is more incisally, like roughly 2 millimeters to preserve the ferrule effect. So just not to damage the structure of this already damaged teeth too much. And then I scan this and I provisionalize, the patient goes home. And then this is very nice. I ask our technicians, and this is what we do a lot now. So imagine just as they would make the provisionals today, they can make the provisionals in a transparent PMMA, right? You just put a transparent PMMA instead of the normal PMMA and you have your final design. But in the inside of this, you can design your ideal abutment, okay? Which means it's gonna be like coping, but inside is the ideal abutment that guarantees like uniform thickness for the final ceramics. And it has also like a cylinder for the material to flow out. this has amazing fit, and you can also do at the same time, you can do the transparent one and also the provisional. So you can do this before you're gonna do the procedure and finish in one session. And then when I get this, I'm gonna sandblast, etch, silane, the bonding process. Then I take like an opaquer. I found something from the lab, resin based. I block the metal, and then I fill in the scopings inside with the like warm opaque composite, like dentin composite, and you just put it in on the chamfer and you cure. Then when you cut this, because you're not going to be able to remove, when you cut this off, you're going to have like a beautiful abutment according to your final design, which otherwise for me with my hands is a lot more difficult to do freehand, because you build it up, then you have bubbles, then you add, you remove. It's not easy. And you can see this is what I want ideally according to my final design. This is the silicone guide for my finals. And then you can see I only solved part of the problem, because I was able to block the centrals, but the laterals still in the area of ferrule, I still have like dark. And here in this area, we plan to stain inside. Here's a little bit more stain put just to show on the slide better, but you have to put a little bit just in that cervical area. And then you do the trying, okay? When everything's okay, and this is the day you're gonna bond, and this case I did with Gustavo and Marcelo Giordani. And we always do like this. At the day of the bonding, we do the trying. Then they are gonna take like the soft tissue grafts, and they are gonna create the tunnel, the pouches, place the soft tissue grafts, and just place the stabilizing sutures of the grafts. Then the second they do this, I take the rubber dam, isolate everything. I can bond. I can clean the cement very well. And the last thing they do, they come and they put like a composite in the contact area and put the final sutures to bring the tissue down. So this is how we solve also the dark of the tissue. So this is how it looks after healing. This is another view from the sides, and this is in polarized light. So I just want to make like a short overview of the tools you have when you go monolithic and you don't have the option to layer. This is how you manage color. These are 3 options. Probably there's more, but for me, these 3 are probably the most common sense and the best ones to manage almost every scenario. So I think that's about it. I hope I was okay with time. So thank you guys very much, and be safe.
Thank you, Florin. Thank you, Florin. It was a pleasure to have you here. Yeah. Oh, I have different questions. Somebody asked you, which stains do you use? Which brand?
We use the Evocolor now.
Evocolor,
but there is a
from
problem
Evocolor.
with that, because they stop. Yes, because I understand they stopped manufacturing the one we use now. So we use the old one. I haven't really tried the new one yet.
That Evocolor stopped?
I think so.
No.
I think they change. No, they change from the paste to like the powder one, and the liquid, which is a bit of a technical difference.
Okay.
That's what I know from our technicians.
Okay. Other men ask you, if this stain inside the veneer, the bonding is the same?
Well, technically speaking, if you just stain inside, you lose adhesion because the stain is a metal oxide. But you can fire a glaze on top of it, and then you have again adhesion. You can etch normally and everything. That's why you have to increase always the cement gap. So not the margin gap, which affects your precision, just the cement gap. You put like an extra 50 microns to account for the extra layer of glaze.
Okay. And other question is, what monolithic material do you prefer?
I prefer Empress CAD Multi from Ivoclar. I think this is my first option. My second option is another, so I like a lot this Leuci ceramic. The second option would be like Trilux Forte from Vita, which is a feldspathic. Okay. So for this type of cases, I think these two materials are the best ones for me.
Perfect, Florin. Thank you very much. Yes, was nice.
Thank you, August.
See you again.
It's been a pleasure. See you.
Okay.
Bye.
Stay at home. Yes, and take care.
Yes, you too. Take care.
Bye.
Bye.
See you.